So let's start with our respiratory disorders. So first, we're going to talk about ventilation. So that's the process of actually breathing air into and out of the lungs. It's affected by our intercostal muscles, so the muscles in between our ribs, our diaphragm, our ribs themselves, our brain, and then chemoreceptors. We have our normal values that we need to keep in mind for our pediatric population. Their respiratory rate is going to be much faster than an adult's until they get to be about 6 years old. Then we'll be back down to adult values. And it's important to remember that our oxygen saturation should be greater than 90 in any child. As our pulmonary or our respiratory tract is developing, our pulmonary structures start to mature in a very orderly fashion during fetal life. At 24 weeks gestation, the infant starts to develop their own surfactant, which keeps the alveoli from collapsing during respirations after birth. So if they don't have that surfactant when they take a breath in, their alveoli will open, but then they collapse as soon as they exhale. So then they have a really hard time getting them back open without that surfactant. We do see spontaneous respiratory movement in fetuses, but the gas exchange doesn't actually happen until they're born. When they're still in utero, all their gas exchange happens through the placenta. And then by 35 weeks, we expect the lungs to be fully developed and the fetus to be able to survive outside of the uterus without a lot of intervention. Some things to watch out for with chronic lung disease. If we persistently have an elevated CO2 level and a low oxygen saturation, it's going to stimulate the brain to increase our respiratory rate. So that's why in these chronic lung disease patients, you will see them consistently be tachypnic. That's their body's way of compensating. Their receptors are going to become a lot more tolerant to those high CO2 and those low oxygen concentrations. So if we provide too much supplemental oxygen, we can end up causing them to have a decreased respiratory effort because their body is used to having so much more carbon dioxide in it. So one of the first conditions that we're going to talk about is nasopharyngitis. So that's going to be conditions like coryza, which is an acute cold, allergic rhinitis, which is just your common allergy symptoms, and then upper respiratory infections. So everything I have going on right now. You guys are getting the good side of it. Friday, I didn't have a voice. So nasopharyngitis is all of those common conditions. So colds, allergies, upper respiratory infections. It's important that we treat children with small amounts of their favorite fluids frequently to prevent dehydration. So whatever they will drink, whatever makes them feel better is what we want to give them so that they don't get dehydrated. When we're talking about acute pharyngitis, we're talking about viral or strep infections. So it's important that we treat those quickly to avoid the complications that you see listed there. So if we don't treat a strep infection, we can have things like rheumatic fever, glomerular nephritis. Those are the two big ones that we need to watch out for. Sinusitis is where we have inflammation of our sinuses that's going to require antimicrobial therapy. Our sinuses aren't fully developed until we're 18, so it's really easy for our pediatric patients to end up with infections. And then another really common condition is croup. The fancy word for it is laryngotracheobronchitis. And that's that barking cough that you hear in our kids. They're going to sometimes have inspiratory stridor, and anytime they cry or get agitated, that barking cough is going to worsen. So they're going to have more inflammation in their airway and have more trouble breathing the more worked up they get. So we treat this by providing humidity. So at home, you can put them in the bathroom and just run the shower and let the steam from the shower create that humidity at home. Otherwise, in the hospital, we can use a humidifier to help relax the airways. And it's really important that we don't give opiates because they're going to be a sedative and decrease the child's overall respiratory drive. So even though they're going to be worked up and agitated, we don't want to use opiates to help keep them calm because we don't want to decrease their respiratory drive. And there's actually a sound clip in the extended PowerPoint that gives you an example of that barking cough that you hear with croup. Epiglottitis, we've talked about this before. It's going to be swelling of the tissues above the vocal cords caused by H flu. It's going to have a rapid onset. The course progresses very quickly and becomes life-threatening. The child's going to insist on sitting up and leaning over with their mouth open so that they can drool because they can't swallow their saliva. They also won't be able to cough. It's super important that we never examine the throat with a tongue blade. Don't put anything in the child's mouth that could potentially cause a laryngospasm until you have a tracheostomy set or at least an advanced airway at the bedside. So typically we won't even examine the throat until we have the child intubated or an alternative airway established. And that is really important to remember. Bronchitis is going to be that unproductive hacking cough. We can help children cope with it by giving them cough suppressants prior to bedtime so that they can sleep. And then we have bronchiolitis. So one of the common causes of viral pneumonia is going to be respiratory syncytial virus or RSV. And that is one of those causes of bronchiolitis. If you guys haven't heard on the news, we have a new immunization that we can give for RSV to help treat our neonatal population and help them to avoid coming down with this. And it's way more readily available than the old one used to be. So you used to have to jump through all these hoops with insurance to be able to qualify to get it. And now it's pretty much available across the board, which is really, really great in preventing RSV. So our kids that are going to be most at risk are going to be our 6-month-old to 2-year-olds. They'll have an obstruction of their airway that leads to atelectasis. You're going to see a high heart rate, high respiratory rate, and that overall can lead to irritability and dehydration. The incubation period is about 4 days long. If they are in the hospital, they will be placed in contact isolation precautions. And it's really important that we use good hand hygiene so that we're not spreading RSV to other patients. They might need supplemental oxygen, might need IV hydration until they're able to control their respiratory rate, and we might give antivirals. When we're looking at pneumonia, our symptoms are going to vary with age and depend on the organism responsible for causing the pneumonia. Typically, we have shallow respirations because there's a lot of chest pain associated with pneumonia, just from trying to take a deep breath. Our lungs are just overall irritated, so they're going to have some pain with trying to take a deep breath. The child's going to be lethargic, have a poor appetite, and if they are only affected on one side, they're going to lay on that affected side. We can confirm pneumonia by chest x-ray. We typically also see an elevated white blood cell count. And then we might need to do cultures to figure out exactly what it is that's causing. Then lastly, we have tonsillitis and adenoiditis. So those are your TNAs. After surgery, we want to watch for frequent swallowing while the child is sleeping. That's an early sign that they could have some post-op bleeding. So if you notice that they're swallowing a lot, that can be a sign that we have some post-op bleeding and we might need to do some interventions. We also want to make sure that we're not using any milk or milk products afterwards, because it can cause the child to want to clear their throat as the milk kind of sticks to the throat and lines those mucous membranes. So that could irritate the operative site even more. So avoiding milk, yogurt, cheese, all of those things. When we're talking about asthma, the obstruction is going to be most severe on exhale. So that's why you hear those wheezing sounds when the patient tries to exhale. During the acute episode, they might be coughing, you'll hear wheezing, you'll see that accessory muscle use, indicating that they're having difficulty breathing. You want to watch for signs of air hunger. So those flaring nostrils, those accessory muscles, and then if they get dizzy. Status asthmaticus is going to be continued severe respiratory distress that's not responsive to drugs. So just like our status epilepticus is a prolonged seizure that's not responsive to drugs, status asthmaticus is the same way. So even if we try to give like racemic epi or amnioflin, these patients are not going to respond. So this is going to be a medical emergency. It's going to require us to have an advanced airway to support their breathing. Cystic fibrosis is another common pediatric respiratory disorder. It is a multi-system disease in which thick viscous secretions affect our respiratory system, our digestive system, skin, and reproductive systems. So with our respiratory system, you just see those obstructions caused by the thick secretions. Those also prevent digestive enzymes from flowing into the GI tract. So it's going to result in poor absorption of the food. You'll notice these patients will have bulky, foul-smelling stools that are sometimes frothy because of the undigested fat content. And then they will lose electrolytes through their sweat in their skin. These kids tend to be like always clammy, always have some sort of sweat factor going on. And their sweat will be very salty. And that's one of the things that we use to diagnose cystic fibrosis is we do a sweat test where we wrap these kids up, we get them real nice and bundled and force them to sweat. And then we analyze their sweat and we'll see that increased saltiness. So those increased chlorides in their sweat. And then sometimes we can have infertility because of the secretions that are going to decrease sperm motility and create thick cervical mucus that will inhibit the sperm from reaching the fallopian tubes. So these kids have a restricted diet. It needs to be high in sodium and protein because they're going to excrete these and use them a lot faster than our normal population. They'll also be on medication. So we will give them pancreatic enzymes to help alleviate that deficiency. And then we'll also have lots of respiratory medications to help thin their secretions and help them just have a better overall response to being able to breathe. We can do things like postural drainage, so moving them around and helping them to clear their airways. You can see patients either have cups that we use and we do percussion, or you can see that whole vest that they put on that vibrates their entire chest and helps to loosen those really thick secretions. So those are things that we do for postural drainage. And then it's so important that we prevent infections for these patients. They're already at such high risk for having an immature immune system, and then we add all of these factors on top of it. So prevention of infection is crucial for them. Even things like a minor cold can be really detrimental. They also need periods of rest. So if you think about trying to do your normal everyday life, but breathing through a straw, that's essentially what they feel like all the time. So they have a really hard time keeping up with everyday activity. So they need lots of built-in rest periods. They're also going to need continued medical support throughout their life. This is a chronic disease. There's no cure for it. So they're going to have lots of appointments with all the different specialists. And then they're going to need that emotional support for dealing with a chronic illness. Our last two diseases are bronchopulmonary dysplasia, or BPD, and that is a fibrosis or thickening of the alveolar wall and the bronchiolar epithelium. So that's going to be really common in our premature infants that are on mechanical ventilation for a long time. So that constant beating of their lungs and forcing their lungs to work a little bit faster and better than they're developed is going to cause this bronchopulmonary dysplasia. So we see it in our preemies that are intubated for a really long time or on CPAP for a really long time, and we have trouble getting them off respiratory support. And then lastly is SIDS, sudden infant death syndrome, and that's going to be a sudden unexpected death of an apparently healthy infant between 2 weeks and 1 year of age. So their risk period typically peaks between 2 and 4 months of age, and that's about the time that you start to see them being able to roll over independently. So that's why we have the ABCs of safe sleep to try and prevent SIDS from happening. There is no particular known cause. So it's that sudden unexpected death. We can do a lot of things to try and prevent it, but sometimes it just happens. Do we have questions about respiratory disorders? Pretty quick, but you get the highlights there. So we'll go ahead and move on to our cardiac disorders. So congenital heart disease can be caused by genetic, maternal, and environmental factors. It's not a problem for the fetus because they have that fetal maternal circulation, so they're not reliant on their own circulation to be able to be successful. But at birth, the infant circulatory system has to take over and provide for their needs. So we have two different types of congenital heart disease, cyanotic and acyanotic. So whether you stay pink or whether you turn blue. So cyanotic conditions are conditions that make you turn blue. Acyanotic, you can stay pink. We can categorize them into different groups depending on what they do to our blood flow. So if they increase our pulmonary blood flow, we likely have an ASD, a VSD, or a PDA. So an ASD is going to be an atrial septal defect. So that's going to be an abnormal opening between the right and left upper chambers of the heart. And then a VSD is going to be the same thing, but it's going to be in the 2 lower chambers of the heart. And then a PDA is part of the fetal circulation that's completely normal. It's a duct from the pulmonary artery to the aorta, and typically it closes within a couple days of birth. If it doesn't close, then that's when we get this patent ductus arteriosus that's abnormal. We can treat that with indomethacin or ibuprofen. If it's really severe, we might have to do surgery. Some defects that obstruct blood flow are going to be our coarctation of the aorta, and we're going to talk about that more in detail, but that's going to be a kink or a pinching in the aorta that's going to cause increased pressure and make it really hard for the blood to flow properly through the aorta. Tetralogy of Fallot decreases our pulmonary blood flow, and it is a combination of 4 defects. We're going to talk about that one a lot because there are some certain interventions that we need to remember. And then mixed blood flow is going to be our hypoplastic left heart syndrome, where our left ventricle doesn't form, or our truncus arteriosus, where we get this really wide vessel instead of differentiating between our 2 different vessels. So a shunt is going to refer to the flow of blood through an abnormal opening between the 2 vessels of the heart. So you can see a shunt in any of those openings, like an ASD, a VSD, or a PDA, where the blood is just either going the wrong direction or it's going back and forth, and you have a mixed shunt. And it's important when we're looking at shunts to remember that blood is always going to flow from the area of high pressure to an area of low pressure. So it's always going to take the path of least resistance. That's really important in understanding all of these defects and why they present the way that they do. So when we're caring for any patient with congenital heart disease, some of the things that we see an increased pulse and respirations. We see delays in their growth. We can see difficulty breathing, or we can see that dizziness when they're standing. They'll have overall fatigue, and they're at increased risk of upper respiratory infections, especially if they've got that increased pulmonary blood flow. We need to encourage these children to avoid competitive sports. They're obviously going to be at a disadvantage of not being able to breathe as well, and then that increased cardiovascular work. If we stress our heart out even more with competitive sports, we're going to be at risk for heart failure. They also need nutritional guidance. So these patients require high calorie, small, frequent meals to avoid fatigue overall. Even the act of eating is going to put a lot of stress on their bodies. And then they need to pay attention if they're in high altitudes or cold environments, because that can cause increased stress on the respiratory system. So coarctations, like we said, are going to be kinking or restrictive disorders. It's going to be a narrowing of the aortic arch or the descending aorta. We diagnose this with an aortogram, and we can also see things like higher blood pressures in the upper extremities above the kink and decreased blood pressures in our lower extremities that are going to be after the kink. And if we leave it untreated, we can end up with hypertension, congestive heart failure, and we can end up with infective endocarditis, so an infection directly into our heart muscle. So a tetralogy of flow, remember we said it was 4 defects, and it's a cyanotic heart disease that causes our unoxygenated blood to enter our systemic arterial circulation. So that's what causes that blue coloring. It includes stenosis or narrowing of the pulmonary artery, which is going to decrease our blood flow to the lungs. Also hypertrophy of the right ventricle. So it enlarges the right ventricle because it's forcing it to work harder to pump the blood through the narrow pulmonary artery. And then we have dextroposition of the aorta, where the aorta is going to be displaced to the right, and the blood from both ventricles is going to enter, as opposed to just the one side. And then we have a VSD, so that defect, that opening between the 2 ventricles. Paroxysmal hypercyanotic episodes are known as TET spells. So they happen during the first 2 years of life, and you will see all of a sudden this patient will turn super blue, have respiratory distress, be weak, and they can pass out. It can last up to a couple hours, and it has kind of a similar situation to the post-ictal state on seizures. So immediately following a TET spell, the patient's going to be really lethargic, and all they're going to want to do is sleep. The important thing for us to remember is anytime you witness a TET spell, you want to place the child in a knee chest position. So for our infants, you just want to tuck their knees to their chest as quickly as you can. For our older toddlers, you might see them self-correct. So they might be playing, and then all of a sudden they're just going to stop and they're going to squat. And they're going to stay in that squatting position until they recover from the episode. So that's going to use the pressure in our abdominal cavity to force pressure into the heart and help that blood flow better. So that's their way of recovering themselves, is increasing their blood flow. Do you guys have questions about that? Does that make sense? Okay. When we're looking at congestive heart failure, some of the early signs that we see in infants are going to be tachycardia at rest. So their baseline heart rate is going to be elevated. They're going to fatigue easily during feedings, and we might see sweating on their scalp and forehead. Sweating is pretty abnormal for infants. So anytime you see sweating outside of environmental factors, there's something else going on. They'll have difficulty breathing. And the big thing that you notice is a sudden weight gain. So it's really important that we do daily weights on our congestive heart failure patients, because that's going to be one of the easiest indications that something is going wrong. We want to make sure that we're organizing our care so we give them long periods of rest where they're not going to be disturbed. If they're awake ahead of their feeding schedule, we want to go ahead and feed them, optimize that time that they have the most energy, and then make sure that we're doing those small frequent meals. They might eat way more often. They might eat every 2 hours instead of every 3 or 4, just because they don't have that stamina. And then we can supplement with oxygen to relieve that shortness of breath. And then we'll give medications according to our orders and checking our dosages for safety. If we see them maintaining a consistent weight, that can be a sign of proper medication administration. So that is a sign that we want to see. It means parents are being compliant with their meds, they're working effectively. So if they keep that consistent weight and we're not seeing these sudden spikes in weight or sudden drops in weight, we know that we're on a good medication regimen. Then, like we talked about, daily weights and accurate eyes and nose. Rheumatic fever is going to be an autoimmune disease that occurs as a complication of an untreated strep infection of the throat. So this is why it's so important that we treat strep infections and that we follow through with the entire course of antibiotics. So it's a systemic disease that involves our joints, our heart, our nervous system, our skin, and our subcutaneous tissues. Penicillin is going to be our drug of choice to eliminate our strep infections and prevent the permanent damage caused by rheumatic fever. So that permanent damage to the heart. We typipally start with antimicrobial therapy until the acute infection is treated, and then they'll be on chemoprophylaxis monthly for a minimum of 5 years. So they are going to be on extended antibiotics for 5 whole years. And the whole point is to make sure that that infection does not come back and cause rheumatic fever. So it's a preventative measure to make sure that we don't have an untreated infection. These patients are going to need lots of rest periods. They're going to have pain and fever associated with the swelling in the joints. So we're going to be on anti-inflammatories. We might need steroids, aspirin to help with those pain and fevers. And then in the event of cardiac failure, we would have additional management for that. The way we remember the criteria are going to be Jones mnemonic and the Peace mnemonic. So those will go through all of your different major and minor criteria of rheumatic fever. And that's going to be in the extended PowerPoint for you guys. It's laid out really nicely. When we're looking at systemic hypertension, so prolonged elevated blood pressure, we do a lot of nutritional counseling in our pediatric population. So nutritional counseling and then promoting exercise is going to be the best way to reduce hypertension in the pediatric population. So just like adults, we recommend the DASH diet, which is going to be low-fat milk products, fruits and veggies, fish and poultry, low sodium, no highly refined or processed foods. We're going to encourage them to have a healthy weight, so they might need to lose some weight, increase our aerobic exercises, and then be counseled on the adverse effects of drugs, alcohol, and tobacco on our blood pressure. If we have secondary hypertension, the underlying disease is going to be what we're going to treat to relieve that elevated blood pressure. And the last thing that we have to talk about is Kawasaki's disease. So it is an illness with an unknown cause that typically presents after a viral infection. Our diagnosis is going to be made by our clinical signs and symptoms. We don't have any lab tests that we can do to say that you have Kawasaki's disease. So it causes inflammation of the vessels in the cardiovascular system, which is going to weaken the walls of the vessels and can result in aneurysms. And those can lead to thrombi or blood clots to form, which can be a life-threatening disorder. So the things that you see those bright red eyes or conjunctivitis. They have a strawberry tongue, which you can see in the picture. It looks just like a strawberry. And then they have peeling of their skin. They can have rashes and cracked lips. So we give them IVIG if we can catch it early and prevent the development of the damage to the heart. We can give them aspirin for anti-clotting properties. And then if they end up with those aneurysms, then we give them warfarin or Coumadin to make sure that we aren't having blood clots. And that is the end of our PowerPoint. Does anybody have any questions on the information that we covered?
Okay.
Okay, so let's go ahead and move to our Kahoot. And I will get this up and going for us. I think this is it. Let me, there we go. So I will let you guys get logged in here. I doubt we will have enough time to get through all of it, but we'll at least make a good dent in it. Okay. I just stuck the pin in the chat for anybody that needs to join us late. Otherwise, you can just follow along on my screen and we will go ahead and get started.
Will we be able to access this after it's just recording?
Yes, sorry, there was another problem with it. We had listed in one of the questions retarded growth as an answer, and Kahoot blacklisted us until I changed it. So now it should be available. So acute coryza is our common cold. So I feel like that's going around right now.
Oh, another thing I meant to say is when you're screen sharing, I noticed like you have you have our faces in it.
Okay.
Where when we go back and review it, like we can't really see the what you're actually going over and stay on track with what
Okay.
you're going over. Like we could see half of the screen, the other. So
Okay.
like I guess the only way to fix that is like when you're screen sharing, to like minimize the people that's in the chat in the Zoom to only just
I'll have to
yourself.
look at it. That's why I also attached the PowerPoints so you can still see them. Signs and symptoms of congenital heart disease are going to be increased pulse, delayed growth, upper respiratory infections, increased respirations, difficulty breathing or that dizziness on standing, and then fatigue. So all of those are signs of congenital heart disease. Oxygen is carried to the body by erythrocytes or our red blood cells. It's going to be our oxygen transporters. So I think I actually said this wrong in class. RSV is going to require droplet isolation. So those respiratory, when they cough, we need to watch for those droplets. So we will have to do gown, glove, mask, goggles for these patients. So the big fancy word for acute croup is going to be that laryngotracheobronchitis. Atelectasis is going to refer to those collapsed alveoli, typically caused by a surfactant deficiency. Tachypnea is going to be our increased respirations. The opposite of that would be bradypnea, which is going to be our slow respirations. So we give those supplemental pancreatic enzymes to help facilitate digestion of nutrients in our cystic fibrosis patients. So those get mixed in with their bottles, or typically we can give those in applesauce too for our older kids. If we have a fever with an upper respiratory infection, we want to treat the fever as indicated and then give small amounts of their favorite fluids so that we're not having dehydration. So the fluids are going to be really important for them. What does asthma cause? So asthma causes increased school absenteeism. So the more often that they're having asthma attacks, they're having to come out of class or go home early for treatment. And then asthma is going to cause increased doctor visits and hospitalizations to make sure that we're tailoring that treatment regimen. Most common reason for pneumonia in infants is going to be RSV. Increased pulmonary blood flow is going to be caused by our ASD, VSD, and PDA. So those holes in between the ventricles or the atria, and then that extra vessel with our PDA. Swallowing frequently after a TNA is going to be an indication of bleeding from the surgical site. So we'll definitely want to do an assessment, make sure that we don't see any bleeding that needs to be cauterized. Signs and symptoms of respiratory distress are going to be increased breathing rate, confusion, and then those abnormal breath sounds. So we see tachycardia along with it instead of bradycardia. We want to keep our oxygen saturations above 90 in our children. So if a child gets cystic fibrosis, but neither parent has cystic fibrosis, it means that both parents happen to be carriers for the gene, and the child just happened to get both copies from each parent. Which fluids are most appropriate for a 5-year-old with dyspnea and fluid loss? That's going to be room temperature water. So we want to avoid anything that's cold because that can cause, especially milk, can cause more lining of the mucous membranes. Then we want to avoid carbonated beverages because they're going to continue to dehydrate. And same thing with those iced fruit juices. We can cause some of that difficulty with swallowing. The first 72 hours after a smoke inhalation injury is going to be the greatest risk for that pulmonary edema to develop. Let's get one more in, guys. 2 more in. What findings are expected when measuring the blood pressure on all 4 extremities of a child with a coarctation of the aorta? So we'll see lower blood pressures in the legs than we see in the arms because the blood's not flowing as well to the lower extremities. Okay, last question for us today. Cystic fibrosis patients need a diet high in sodium and high in protein because they're going to use a lot of that protein in recovery, and then they're going to have that sodium be excreted through their sweat. So it looks like JW is going to be our winner today since we're going to stop here. Good job, guys. I did want to go over our plan for next week.